Assalamu alaikum, everybody. Good evening, everybody, and welcome to our tonight's webinar. I am Saad Hussein. I'm a consultant heart failure and transplant cardiologist at King Saud bin Abdulaziz University for Health Sciences and King Faisal Specialist Hospital. I would like to welcome you today about this about a session about management of heart failure. I'm glad that we have two excellent speakers that hopefully will share with us some of the updates about heart failure management. As everybody know, heart failure is becoming now a major burden in all of our hospitals. Everybody, especially who works in cardiology, will say that up to 30–40% of patients admitted to the hospital nowadays are having heart failure. In the past, heart failure was a frustrating thing. However, we noticed that over the past few years, there have been a lot of excitement and a lot of new therapies that came in the market that hopefully will improve the heart failure management. So today we're going to discuss a couple of very important topics, and maybe we'll start with the first one. I'm very happy to introduce my good friend, Dr. Ali Masood. Dr. Ali Masood is a consultant cardiologist. He is also a consultant interventional cardiologist and heart failure cardiologist, and the chairman of the cardiology department at the Specialized Medical Center. He's also an associate professor of medicine at Al Faisal University and also works at King Faisal Specialist Hospital and Research Center. Dr. Ali will talk to us today about a contemporary overview of acute heart failure management, which is always a challenging thing to talk about. So please go ahead, Dr. Ali. And as a reminder, we're going to take questions at the end of both of the presentation. Go ahead, Dr. Ali.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank Dr. Msaad for this nice introduction, and I would like to thank as well Saudi Heart Association and AstraZeneca company for organizing this important mini symposium on touching on very important clinical problem related to cardiology and clinical practice in outpatient setting as well as in the emergency room and inpatient setting. My role in the coming 30 minutes to talk about acute heart failure, which is, as Dr. Saad mentioned, very difficult subject to cover because of many reasons. Because it's heterogeneity of the patient and this, the presentation. Acute heart failure in general did not receive attention as for chronic stable heart failure. So paucity of evidence-based therapies related to acute heart failure. It is increasing in incidence because of aging population, and we're doing great job on managing other medical problems that keep patients live longer. Acute heart failure is also associated with very high risk of mortality and readmission rate and poor prognosis. Let's agree upon the definition of acute heart failure. It can be defined as sudden or gradual onset of signs or symptoms of heart failure requiring unplanned office visit, emergency room visit, or hospitalization. The global burden of heart failure is huge because of, as I have mentioned, aging population, and because of very high risk of mortality and morbidity related to this clinical problem. You can look at this slide that shows how world population are getting older and older with time. And this graph taken from the World Health Organization, and you see by 2050, the people older than 60 will be double than now. So you would expect more patients affected with heart failure. And in association to this, there will be increased cost and increased hospital admissions for patients diagnosed with heart failure. Heart failure is a common problem. Its prevalence worldwide range from 1 to 3%, depends on the country and the geographical area. Unfortunately, we don't have precise data to relay or to refer to know the prevalence of heart failure in our country. But I think we can extrapolate other data that was published in Europe and North America, because probably the lifestyle and risk factor prevalence is probably similar. So in fact, probably we're probably higher, because the prevalence of diabetes in our population is much more than other countries. So I would probably assume heart failure prevalence in a country like Saudi Arabia would range from 1.5 to 2.5%. The number of hospital admission as well is very high if you compare it. In fact, it's the number one reason for hospital admission worldwide for those who are older than 65. So it is really a major problem with regard of prevalence, mortality, and hospital admission. And the problem of this clinical condition, that when you admit one patient, or when someone got admitted, the chance of readmission is very high too. So the chance of re-hospital admission in 30 days is 27%, in 3 months 40%, in 6 months 50%, referring to my clinic database. Mortality in 30 days, 12 months, and 5 years is very high too. These patients, when they got admitted, they usually don't go back to their baseline. Patients with acute heart failure, they have progressive disease. So when they get admitted because of worsening symptoms, we admit them and try to bring them back to baseline. They improve to a degree that we can discharge them, but they will never go back to their baseline. And when they get second admission, they will not go back to this baseline, which is already worse than before. So it's a progressive disease with more number of admissions and with time. So we are really dealing with deadly clinical condition. Looking at international data, the mortality rate is high with patients with HFrEF, and more than 70% of these patients will die within 5 years of hospitalization with heart failure. And 1 year risk of death in patients with HFrEF is 10 to 12%. That's in fact worse than most of cancers that we deal with currently. So acute heart failure is more deadly than most of the cancers, that probably they draw more attention and care if you compare it to heart failure. Patients worldwide are affected by heart failure, and prevalence is expected to increase with aging population, as I have mentioned. Another issue is related to presence of diabetes in conjunction with heart failure. Presence of diabetes have 2.5-fold greater risk of developing heart failure than patients without diabetes. That's why I thought probably we have higher prevalence of heart failure because of endemic, because our population area is endemic with regard of presence of diabetes. Let's talk in specific about Saudi Arabia. In fact, I'm going to talk in more detail about the clinical trials related to heart failure, acute heart failure in specific, that was published related to Saudi Arabia. But let's first extrapolate the prevalence of heart failure to the Saudi Arabia. Probably you have around, if we choose like 1.5 to 2, probably you have around more than 680,000 patients affected with heart failure. And unfortunately, the mean age of patients admitted with acute heart failure in Saudi Arabia is 10 years younger than those who are admitted in other international registries like ADHERE registries and other large scale trials related to acute heart failure. As I told you before, the prevalence of diabetes is 60% in patients with acute heart failure, which is double the rate reported by global acute heart failure registries. Now, I told you this problem is associated with increased risk of mortality, increased risk of hospitalization, and the cost of heart failure is huge if you compare it to other clinical problems. In fact, it is more costly than all cancers combined. And the cost of heart failure is driven mainly by hospitalization, i.e. dealing with acute heart failure patients. And the length of hospital stay range from like 5 to 12 days, depends on the country and the health the system that you deal with, that you look at. And in our country is not different than this. The length of hospital stay of mean of 6 to 8 days. We're trying to do good, and the number of hospital admission decreased if you look at the trend over years in some country, but in fact in some country the rate of or the percentage change in number of hospitalization increases. And if you look at the heart database that was published in New England Journal of Heart Failure 2014, evaluating patients admitted with acute heart failure in Saudi Arabia, you will find the mean age of 61, which is 10 years younger than international data. And presence of diabetes, as I have mentioned before, is 64% if you compare it to other countries, which range from 40 to 30%. So definitely our patients present earlier. That's mean there's probably they are affected with risk factors in earlier, and the number of population probably is higher. And most of these patients, and the hospital mortality in our population is 6.5%, which is quite high if you compare it to ADHERE registry and optimized HF registry. As I mentioned in the previous slides, those who are admitted with acute decompensated heart failure, they do worse than de novo heart failure patients. So it is a progressive disease. So with each admission, the mortality increase, the risk of readmission increase, the prognosis gets worse. We have Gulf Care as well that evaluated acute heart failure in Gulf region, and it is probably similar to the heart registry. So the mean age was 59, which is much younger than in other international registries, and the presence of diabetes is quite high as well. I'm not going to spend a long time on talking about prognosis and hospital admission and mortality. Let's talk about the management of acute heart failure. Unfortunately, heart failure did not get enough attention as if you compare it to chronic heart failure. And if you look at the published guideline, Heart Failure Society of America, or AHA, or European Society of Cardiology, most of the recommendations related to acute heart failure are expert opinion or level of evidence C. And few of these recommendations are A and B. So we're dealing with probably not evidence-based, but eminence-based medicine. When you receive patients with acute heart failure, you should think of factors that may trigger acute heart failure, and this will help to reduce prevent future events and proper management of these patients. So the most common triggering factor is acute coronary syndrome. Tachyarrhythmias like atrial fibrillation and ventricular tachyarrhythmias are other precipitating factor. Excessive rise in blood pressure is another major issue. Infections, non-adherence to salt fluid intake of medication is a major risk factor for acute heart failure. In fact, 50% of hospital admission in some registries is related to non-adherence to either fluid and salt intake or medication. So this is very important. And this all related to education. So if our patients are much more educated, we probably reduce the chance of hospital admission significantly. Now, let's talk about initial management of patients admitted with acute heart failure. When you suspect acute heart failure, you need to rule out the cardiogenic shock. You need to make sure that the patient is not in shock. If he is in shock, you need to take him to fast track and to assess him for emergency interventions, including circulatory support, either pharmacological or mechanical. If the patient is not in cardiogenic shock, we need to evaluate respiratory failure, and make sure they are not in need of ventilatory support like oxygen or non-invasive positive pressure ventilation or mechanical ventilation. And then you need to identify acute etiologies or triggering factors for acute heart failure, like what we mentioned in the previous slides: acute coronary syndrome, hypertensive emergencies, arrhythmias, acute mechanical causes or pulmonary embolism, or other precipitating factors. Then you need to initiate specific therapy according to the etiology and the presentation. Patients admitted with acute heart failure, we need to look at two things. First, the perfusion and congestion. We express congestion. We look at is the patient wet or dry. And by the way, most of patients admitted with heart failure are wet or congested. If they are congested, then you need to evaluate the perfusion. If they are well perfused or no. So if they are well perfused, that's mean they are wet and warm. And these patients typically have elevated or normal systolic blood pressure. So if you have patients who are wet and warm, then you need to consider diuresis to bring them to a euvolemic state, and consider vasodilators. And if the patient are responsive to the medical therapy, well and good, or you may consider ultrafiltration and other intervention to improve their situation. Let's go to the other types of patients or other group if they are dry. If they are dry and warm, so they have adequate perfusion and compensated, then you need just to adjust their oral medication, and these are probably the least risky patients. If they are dry and cold, i.e. hypoperfused and hypovolemic, consider fluid challenge, consider inotropic agent if still hypoperfused. If the patient wet and cold, these are the worst scenario, and this is the poorest group. You need to maintain their blood pressure and perfusion by inotropic agents, consider vasopressor in refractory cases, and they need diuretics to improve their perfusion. So just to simplify what you have seen in the previous slide, you can classify these patients into 2x2 table according to their presentation. Look at congestion and perfusion. The worst group is cold and wet, and these usually need CCU admission and inotropic support. The commonest group is this B, warm and wet. They respond quickly to IV diuretics. And the other groups, A and L, they are probably easier to deal with. Now, let's look at classification and their like when you get patients who's admitted, as I told you, around 70% of these patients are wet and warm, so they are congested and hypertensive. What will happen to them on discharge? We will manage to probably move most of them to be dry and warm. 59% out of 60, they will be dry and warm, so good to be discharged. And around 40% of them, they will still be wet, i.e. they are not back to their euvolemic condition. And this patient chance of readmission is much higher. And I want to emphasize more on this point that you need really to keep your patient euvolemic on discharge to minimize the risk of hospital readmission. Let's talk into details about the therapeutic targets related to heart failure. First, congestion, as I have mentioned, and second, intervention to decrease blood pressure and afterload, and the third, intervention that directly improve cardiac performance. So congestion will deal with it by diuretics. For blood pressure, we'll use vasodilators. And for improving cardiac performance, we need to use inotropic support. Congestion is one of the most important mechanisms that are responsible for acute heart failure admission. And it carries prognostic importance. So congestion associated with deterioration of renal function, increased chance of readmission, increase hospital mortality on short and long term. So we need to pay more attention to volume status, and probably we need to be more aggressive in dealing with congested patient, considering their renal function and electrolyte balance and their tolerance to our interventions. Because of congestion, most of the diuretics are the most common medication that are used for acute heart failure. As you see, 90%, approaching 90% of patients admitted with acute heart failure will be on IV diuretics. Diuretics is old medication. Do you think we need to know more? Do you think we need to evaluate it more with clinical trials? Yes, that's true. And in a study identifying unanswered questions in heart failure management, 50% of the questions were related to the most appropriate use of diuretics. So probably the unknowns related to diuretics is probably is more than that we know. What we know if you look at the evidence-based practice. Let me share with you some important clinical trials related to use of diuretics. First of all, time to furosemide treatment and mortality in patients hospitalized with acute heart failure. This is a relatively recent trial that was published 2017 in JACC, evaluated the time of administration of diuretics for those who are admitted with acute heart failure. And the time limit was 60 minutes. So they divided the patients into two groups: those who received furosemide within 60 minutes of presentation with acute heart failure, or later than 60 minutes. And this was associated with reduction in mortality. So that the earlier administration of this therapy was associated with less mortality and better prognosis. So it's like time is muscle, like dealing with acute MI. Dealing with acute heart failure, we should be on timely manner, and we should not delay the intervention because this is associated with worse prognosis. Those trial is one of the famous, one of probably relatively good randomized trial that was published in New England Journal of Medicine 2011, evaluating acute decompensated heart failure patients if they will receive furosemide either bolus or infusion. And in fact, there was no significant difference between the two. And they divided these patients either continuous or boluses with high dose or low dose. And the high dose was associated with a greater diuresis as expected and higher creatinine. So you would expect elevated creatinine with more aggressive diuresis, but I think it's a matter of balance. So yes, you need to watch the kidney function and electrolyte disturbances, but my recommendation to try to bring your patients to EU volumic status as much as you can, plus maintaining good perfusion to other vital organs. KZHF trial is another important study comparing ultrafiltration in acute decompensated heart failure with cardiorenal syndrome to IV diuresis, aggressive regimen. So they used usually like A, B, and C regimen, and their target for the patients to lose around from 3 to 5 liters per day. So quite aggressive protocol to bring patients as quickly as possible for euvolomic status, using IV furosemide plus thiazide if needed, and sometimes inotropes or renal dose of dopamine to maintain their perfusion as well. And the IV diuresis was, or pharmacological intervention was superior to ultrafiltration. So the conclusion of that trial, KZHF trial, the use of stepped pharmacological therapy algorithm was superior to strategy of ultrafiltration for preservation of renal function. with similar amount of weight loss with these two approach. So ultrafiltration was associated with higher rate of adverse events. So what the message of this trial was proper handling and use of multiple agents for diuresis probably will do as good as or even better than intervention with ultrafiltration or dialysis. The recommended therapies based on ESC, Arabian Society of Cardiology, Heart Failure Society of America, and ACC/AHA guidelines, they recommend the use of diuretics in acute heart failure with volume or with the fluid overload, and this IV diuretics should be in conjunction with thiazide diuretics if the patient are not good responder to IV diuretics. And the guidelines mention or added or add considering dopamine small dose, though it's lack, there is no enough evidence to support its use, but it's been mentioned in the guidelines and someone may consider dealing with this difficult population. If the patient has inadequate response to diuretics therapy, you should think of renal impairment, up-titration of beta blocker as a cause, use of non-steroidal anti-inflammatory, or increased salt intake. How to treat? You need probably to double the dose, add thiazide or other type of diuretics, or consider ultrafiltration if the patient are completely not responsive to IV diuretics. The guidelines give IV loop diuretics as class 1 recommendation, and as you could see, it's level of evidence C. But it's, I mean, this is the standard of care, and you can see its response in your like in minutes when you use it for patients with acute heart failure. The second agent that is very important is vasodilator to improve the reduce afterload and improve the cardiac performance. Vasodilator should be the second agent to be used in addition to diuretics for patients admitted with acute heart failure, especially if they are maintaining adequate blood pressure and perfusion, and they have no symptoms of hypotension. What I can see in our practice that we're probably reluctant to use vasodilator for those with borderline blood pressure. I would probably recommend what has been stated in the guideline. If the blood pressure is more than 90, I think we still can use small dose of IV vasodilators plus IV diuretics and watch the patient for definitely for hypotension or hypoperfusion signs. If the patient are have symptomatic hypotension or they are not tolerating the vasodilator, then you should think of inotropic agents like dobutamine, dopamine, and maybe norepinephrine if the patient are having refractory hypotension. Not to forget thromboembolism prophylaxis for these patients, because these patients usually in the first 48 hours they are bound to their beds and they are not mobilizing enough, so they should have prophylaxis in form of either low molecular weight heparin or NOAC. And other medication should be considered according to their clinical presentation and their coexisting pathologies that they have. The vasodilator that we are commonly using in patients with acute heart failure, the most common one is the nitroglycerin. Nitroglycerin is commonly used, easy to be up titrated, so it's recommended, and we recommend to use it in preferably in the CCU setting. The other agent that we can consider in addition or as alternative to nitroglycerin is Nitro Porcide. The problem with Nitro Porcide is a very potent antihypertensive agent, and it's definitely it needs monitoring and CCU setting, and we need to look for isocyanide toxicity. Dopamine, dobutamine are needed for the wet and calm patients, or cold and wet patient, we usually use dobutamine or dopamine for these patients. Usually we start with small doses and we uptitrate according to their needs. Mirlanon, another agent that are liked by the surgeons and is probably preferred for those with severe pulmonary hypertension. However, in ischemic cardiomyopathy, Mirlanon in some studies being shown to be associated more with higher mortality if you compare it to other inotropic agents. Now, before I move or conclude with regard to pharmacological therapy, let me bring your attention to other intervention that I decided to bring pictures that probably carry much more meaning than 1,000 words. These are patients admitted to their hospitals with acute advanced refractory heart failure. And these patients were offered on emergency basis assist devices, left ventricular assist device, and you can see these patients went back to their life. I mean, they are active in their life. One of them is hunting, fishing, swimming. So with mechanical assist devices, if you have proper, well-established program, you can, in fact, bring these patients to their baseline if they are refractory to advanced medical therapy. This is patients. I like to bring this picture and to share it with the audience when we talk about acute heart failure. This is classical case. This is, by the way, this is something real. It's not like fake picture. It's real picture. This is young chap admitted with acute refractory end-stage heart failure. You see, on mechanical ventilation, taking inotropic supports, bone and skin, cachectic, and this is him post-cardiac transplant. So we have therapies to be considered if these patients with this deadly disease are refractory to advanced medical therapy. And I would like to, before I conclude, I would just like to remind you with challenges that you are facing with patients with acute heart failure. Their number is increasing, hospitalization is high, hospital mortality and short, long-term mortality is very high. So we need to coordinate our care and we need to move toward chronic care models with multidisciplinary integrated care and patients stratified by need and most complex patient being case managed. And we will have to do things differently, improving care and preventing death of patients with acute heart failure. We need to involve policymaker urge to act on 8 recommendations: promote acute heart failure prevention, optimize care transition, improve end-of-life cares, provide equity of care for all patients, appoint expert to lead heart failure across disciplines, and develop and implement better measures of care quality, improve patient education and support, and stimulate research and introduction. And thank you.
Thank you, Dr. Ali. That was very nice and elegant presentation on the problem acute heart failure. And it's a lot of points that you can spend hours and hours talking about. So that was very valuable. So we're not going to take questions now. We're going to just move to our next speaker. I'd like to introduce Dr. Osama Al-Bashir, who is a consultant cardiologist at the Specialized Medical Center in Riyadh. He's also an associate professor of medicine and cardiology at Al Faisal University in Riyadh. He will talk to us today about updates in the management of heart failure with reduced ejection fraction and how can we optimize therapy. Please go ahead, Dr. Osama.
Thank you very much, Dr. Musa'ad, and I would like also to thank the sponsors of this meeting, AstraZeneca and the Saudi Heart Association for sponsoring this meeting. And I thank Dr. Ali for making my job easy by not talking about the epidemiology of heart failure. So he covered it in his presentation. So I'll go straight to talk about, this is the agenda that I'm going to talk, a little introduction, then I'll talk about the ACC, AHA, and the Heart Failure Society of America recent update of guidelines to treat heart failure with reduced ejection fraction. And then we will talk about the newcomer in the treatment of heart failure, chronic heart failure with reduced ejection fraction, that's the SGLT2 inhibitor and heart failure. And we will talk specifically about the DAPA heart failure trial. And we will cover the landscape of the SGLT2 inhibitors and heart failure with reduced ejection fraction, and then we conclude. So my talk is exclusively about heart failure with reduced ejection fraction. And I start with a definition. What do we mean by heart failure with reduced ejection fraction? It is defined as heart failure in patients in whom the echocardiogram shows that the left ventricular ejection fraction is equal to or below 40%. So we will have a little talk about the ejection fraction, and I do ask the cardiologist to excuse me for talking about basic things, but as I know that the attendants are of different levels, the heart failure can be either due to impairment of the left ventricular filling. So that is the old name for it is a diastolic heart failure, when the left ventricle wall does not relax enough. And so that we have a stiff left ventricle, and consequently the filling of the left ventricle will be affected. And the classical, the impaired ejection fraction, impaired left ventricular ejection fraction, the heart failure with a reduced ejection fraction is as the other kind of heart failure, chronic heart failure. Basically, we just mentioned a little bit about a simplified way of talking about the ejection fraction. So this is the amount of blood that pumped out of the ventricle divided by the total amount of blood in the ventricle. That gives you the ejection fraction. So in heart failure with impaired LV function, that's heart failure with preserved ejection fraction, both factors in this equation are reduced. So the amount of blood pumped out of the ventricle and the total amount of blood in the ventricle is reduced. But at the end of the day, the percentage ejection fraction is within normal range. So it is usually classified as 50% or rather 55% and more. While in heart failure with reduced ejection fraction, there is a weakness of the heart muscle itself, and consequently the amount of blood that is ejected during systole is reduced. This is just briefly to talk about the pathophysiology. On the left-hand side here, we have the heart failure with preserved ejection fraction. The old name for it is diastolic heart failure. So usually there is no left ventricular dilatation. Tends to be usually there is a concentric left ventricular modeling, classically in hypertension. And it is associated with hypertension, with obesity, with diabetes, metabolic syndrome, lung diseases, smoking, and other conditions. So the ejection fraction is over when we do it by the echo is usually is normal or low normal, 50% or 55% or maybe even 60% in normal ejection fraction. The heart failure with reduced ejection fraction, that is usually there is a left ventricular dilatation. That's like on the right-hand side of the screen. There is that occurs due to loss of the systolic function. Classically, it's associated with ischemic heart disease and coronary heart disease and other conditions like dilated cardiomyopathy. And both of them, they like half-half, roughly. About 50% of patients with chronic heart failure either have a half ref or half PEF. The symptoms is the same, whether it is the patient has reduced ejection fraction or preserved ejection fraction. So it starts with dyspnea. Patients tend to have fatigue, exercise intolerance. They may have dry cough. When it is advanced, the patient may have trouble sleeping, so they may have paroxysmal nocturnal dyspnea or orthopnea, so they need to sit or use 2 or 3 pillows. As a consequence to the gut congestions, they may have loss of appetite, and then they develop signs of fluid overload, so they may have edema, and they may even have pulmonary edema. They may have a pleural effusion, and they may have ascites, and classically, when we see them, sometimes even they have severe swelling of their feet and ankles. The staging of the heart failure and the functional classification. So the ACC, AHA stages of heart failure, they put them as A, B, C, and D. The patient that we see is usually C. And of course, Dr. Ali talked to us about those with advanced heart failure that needing a transplant. These are D. But the majority of the patients that we see is a C. Because A, these are patients who have, they are without structural heart disease and no symptoms of heart failure, but they have risk factors. They have risk factors. So somebody who's obese, is diabetic, is hypertensive. This is, you can call him class A, still he doesn't have symptoms. Class B is, they have a structural heart disease. So if you, for example, do an echo for him, you may find signs either for systolic or diastolic impairment, but that still the patient is asymptomatic. So he's not only having risk factors, he started to develop structural changes, but he still not has symptoms. And then class C, when he started to have symptoms. So we classify the symptoms, as we all know, the New York Heart Association functional class. Class 1, that is no limitation of physical activity. The ordinary physical activity does not cause symptoms. Class 2, these are patients who have slight limitation of physical activity. They are comfortable at rest, but ordinary physical activity results in symptoms of heart failure. Class 3, that's marked limitation of physical activity, comfortable at rest, but less than ordinary activity causes symptoms. So here, classically, patients will tell you, when I go upstairs, I get shortness of breath, which is normally used to be for him a normal activity. Class 4, that is more advanced, where they have physical, they reduce activity, and they have already symptoms and signs. You know, they already have lower limb edema. They have, you know, they notice that they gained weight due to fluid overload. Okay, now let us just mention about a new tool for a few years now. Or let me very say, the heart failure is a clinical syndrome. So a patient who is the right person to get impaired LV function, whether systolic or diastolic, and then has symptoms and signs of heart failure. So you make a diagnosis, but clinically, you need to do other tests that may help you confirm the diagnosis. So we do chest X-ray when the patient already has signs of congestion, and then you get the classical things depending on the degree of the congestion. Then you need to do an echocardiogram to classify whether the first confirm that the patient has either impaired LV systolic function or diastolic function. We didn't used to have a test, a blood test that would help us. Now we have the pro-BNP, the N-terminal pro-BNP, or you know, this is pro-beta type natriuretic peptide that will help us to, it tends to be elevated. You have to put the age in consideration, because people who are elderly, even a normal, with their normal will be a little bit high. So if you find a patient above 125, that's a little bit elevated, but in an elderly man or a woman, if it is around this range, maybe you would not take it as a sign of heart failure. Other factors like atrial fibrillation, if the patient has an atrial fibrillation on arrhythmia, also the level may be elevated. But in patients who come, like the classical patients Dr. Ali presented, they come to ER with a severe or advanced acute heart failure. Quite often you find that the pro-BNP is in thousands. Now, heart failure hospitalization, Dr. Ali did mention it, is a thing that is now, we look at it, and in clinical trials, it's been a parameter that we use to talk about the heart failure, and we wanted to have medicines that would reduce heart failure hospitalization. So it's become a parameter that you look for it. We know that heart failure hospitalization is associated with mortality, and it represents a marker for significant adverse subsequent prognosis. So I will not spend a longer time about it here. So the difference in the management between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. This will be the last time we talk about heart failure with preserved ejection fraction. From now onwards, we'll talk about heart failure with reduced ejection fraction. But the main difference is that, I mean, we did talk about the pathology, but the main difference, you wanted to see if this patient has heart failure with preserved ejection fraction or heart failure with reduced ejection fraction, because we now for over 20 years, we've shown that certain medications must be given to patients with heart failure with reduced ejection fraction because they reduce mortality, they reduce morbidity. So you wanted to classify these patients to see whether they are heart failure with reduced ejection fraction in order to put them on the guidelines recommended medications. Heart failure with preserved ejection fraction, it did not show a response to the classical medications that we use for heart failure with reduced ejection fraction, that is the beta blocker, the AC inhibitor, or ARB, or the ARNI, or aldosterone antagonist. These are medications that we must use for patients with heart failure with reduced ejection fraction. This was the case up to last week. Only last week, the FDA approved expanded indication for the sacubitril valsartan, the ARNI, for treatment of patients with ejection fraction of or below 55%. That is mid-range EF. The European, they use this term, but the Americans, they do not use it, which were classified. These are classified as heart failure with preserved ejection fraction based on the approval came based on subgroup analysis of the result of the Paragon trial, which recruited patients with heart failure with preserved ejection fraction. So just to remind you, this is came last year. There was a hope that this trial would show now an agent that will help patients with heart failure with preserved ejection fraction, but unfortunately, it did miss the point of statistical significance. But they went and looked specifically to a subgroup of patients with a borderline ejection fraction, and they found that it is useful. So then they approved the sacubitril valsartan for this group of patients. To remind you that in the Paragon heart failure, sacubitril valsartan was not superior to valsartan alone for reduction of cardiovascular risk and heart failure hospitalization in patients with left ventricular ejection fraction of at least 45%. So the common causes of heart failure with reduced ejection fraction is ischemic cardiomyopathy. This is the leading cause. So it is constitutes about 60 to 70% of cases. Dilated cardiomyopathy, hypertensive cardiomyopathy, patients with uncontrolled hypertension for a long time may develop heart failure with reduced ejection fraction, and they may also have heart failure with preserved ejection fraction. diabetes. Now we recognize over the last 2 decades that there is some form of what we call diabetic cardiomyopathy, a patient who never had an ischemic heart disease. Quite often the diabetic, their heart failure will be due to ischemic cardiomyopathy, but they may also have normal coronaries, but still have diabetic cardiomyopathy. We know also the cardiotoxic agents, chemotherapeutic agents like Herceptin that is used for breast cancer. They do reduce the function, the ejection fraction of the heart. Alcoholic cardiomyopathy, classically, it causes also heart failure with reduced ejection fraction. The peripartum cardiomyopathy is another cause, and the valvular heart disease, classically aortic regurgitation and mitral regurgitation. If they are severe and they continue for a long time, this may lead to overload of the left ventricle, and that will dilate, and ultimately they develop heart failure. If a patient has aortic stenosis, severe aortic stenosis, not treated surgically, nowadays even there is an option for elderly to go through a catheter. So to relieve this obstruction of the left ventricle, they may develop heart failure. Now, quickly, we will go through the 2021 update of the 2017 ACC, AHA, and Heart Failure Society of America, the guidelines for heart failures with reduced ejection fraction. This is what published about a month ago. So these are exactly word for word from that update. So number one, it says for patients with newly diagnosed stage C, we did explain what we mean by stage C, heart failure with reduced ejection fraction, a beta blocker, an angiotensin converting enzyme inhibitor, or angiotensin receptor blocker, or angiotensin neprilysin inhibitor, the ARNI, that's like Entresto, they should be started in any order. So as you can see here, these based on the trials that were done back in the 90s, late 90s with the AC inhibitor, and then at the end of the 90s, the beta blocker trials, beta blockers was absolutely contraindicated in heart failure, and then the trials of beta blocker did show that they improve survival and hospital admission, and so it becomes a must for patients with heart failure with reduced ejection fraction. Then in the early 2000s, we will come to it later on, the aldactone, and it's been added. And then we waited for a good 14 years. In 2014, the ARNI, that's the angiotensin receptor neprilysin inhibitor, came, and then we discovered that in this paradigm trial that this is very superior to the AC inhibitor, and it's become a very important agent to use in patients with reduced ejection fraction. The guidelines here, he says each agent should be up-titrated to maximally tolerated to increase the dose, and initiation of a beta blocker is better tolerated when the patients are dry, and an AC inhibitor, ARB or ARNI, when the patients are wet. And Dr. Ali did tell us about who are the dry and who are the wet. So patients with edema, perhaps better start them with an AC inhibitor or ARNI. Patients without edema, maybe then you can start them with a beta blocker. But anyway, you need to start them on both of them. I will stop here when he says each agent should be up-titrated to maximally tolerated dose. Unfortunately, is a very common thing that you see a patient, they make a diagnosis, a patient has a heart failure, they put them on captopril 6.25 milligram twice daily, and put them on carvedilol, also a starting dose 6.25 milligram twice daily, and the patient has been on them for years. So if the patient, this is the starting dose, if the patient is tolerated, it is our job to gradually increase the dose in order for them to get the maximum benefit from these medications. And this is mentioned also here that the up titration. Only guideline recommended beta blockers, that's the carvedilol, metoprolol, succinate, or bisoprolol, should be used in patients with heart failure with reduced ejection fraction. This is the American guidelines. The European guidelines add to this four or three beta blockers. It adds nebivolol, Nebilet. It's by the European Society of Cardiology. It's also one of the beta blockers to be used in heart failure. So tenormin or atenolol is not a recommended beta blocker to use in heart failure. And in fact, the metoprolol that is in the Saudi market here is not the metoprolol succinate that was used in the trial. So among angiotensin antagonists, ARNI are preferred agents. And just because of the cost, maybe still it's in the guidelines, the AC inhibitor or the ARB, but ARNI in their trial, they were superior to AC inhibitor. Renal function and potassium should be checked within 2 weeks of initiation or dose up titration of the ARNI or AC inhibitor. The diuretic should be added as needed, and those should be titrated to achieve a decongestion. If doses in excess of furosemide 80 milligram twice daily are needed, then either a different loop diuretic should be considered or a thiazide should be added. After initiation of beta blockers and angiotensin antagonist, addition of an aldosterone antagonist should be considered with close monitoring of electrolytes. And then here they have added the first time that the sodium glucose co-transporter SGLT2 inhibitor. And this is the rest of our talk, is to talk about these new agents added for heart failure, because we're not going to talk about AC inhibitor or ARB or beta blocker. That is, we've been talking about them for 20 years, but this is a new agent that is added. So we will go through the evidence why it should be now considered for patients with heart failure. So this, it should also be considered for patients with heart failure with reduced ejection fraction and class 2 to 4 patients, because in the study, these are the kind of patients that were tested. This applies to Black Americans because they did a trial there for this vasodilator with hydralazine and isosorbide dinitrate. And here they, because this is an American guidelines, you will not find it in the European guidelines, that you can add these two agents if the patient is an African American. And if the patient's heart rate, patient is in a sinus rhythm and heart rate is still above 70, then ivabradine should be considered. Best treatment to adjust the medication is during hospital admission. So if that is not the case, if the patient did not need to come in hospital, we should bring the patient every 2 weeks to increase the dose if they are tolerating, and we should reach the maximum recommended guideline directed medical therapy within 3 to 6 months. Patients sometimes may be considered for an ICD implanted, that is later on with a follow-up. Hyperkalemia is common when they and abnormal renal function, particularly if they are on aldactone, and so patients should be educated to consider low potassium diet and potassium binders. This is roughly how the previous notes put in the guidelines like this. So ARNI or beta blocker as baseline, and then you consider the aldactone later on, and then you should add an SGLT2 inhibitor. This is the European guidelines. So far, not yet we have a recommendation to include the, because there has not been a recent guidelines, but we expect sooner the guidelines will add an SGLT2 inhibitor to the guidelines. So what is the SGLT2 inhibitors group? This is a new class of antidiabetic medications which reversibly inhibit the sodium glucose transporter 2. So this is called SGLT2 in the renal proximal convoluted tubule to reduce the glucose reabsorption and increase the urinary glucose excretion. These are the SGLT2 inhibitors. So we have the dapagliflozin or Foxega, the one by AstraZeneca. Then we have the empagliflozin or Jardiance. And then we have the canagliflozin here in Saudi Arabia. I think the fourth agent is not yet available in the Saudi market. So where did the story of the SGLT2 inhibitor and heart failure start? Like a lot of things in medicine, sometimes things come by chance. We all know the story of Viagra. It wasn't made for what it is used for now. These medications were anti-diabetic medications. And as you remember, since 2008, any new anti-diabetic medication was supposed to do cardiovascular outcome trial to look for that this agent is not harmful to cardiovascular disease. So this group were, they did their trials, different trials. The EMPEREG looked at almost 100% patients with previous cardiovascular event. The CANVAS, for the canagliflozin, their trial included 34% patients who did not have a previous event, and 66% they had a previous cardiovascular event. And the declare for the dapagliflozin was like 60 to 40% primary prevention and secondary prevention. So when we say they have a previous cardiovascular event, either the majority is patients who had coronary heart disease, but some of them they had peripheral arterial disease or a stroke, a stroke or a TIA. So when they did this trial to make sure that these are safe, to the surprise, we found that not only safe, the EMPA, say for example, prevented the hospitalization for heart failure by 35%. That was not expected. That was expected just at least to show that it does not increase the heart failure hospitalization. The canagliflozin also reduced the heart failure hospitalization by 33%. And the dapagliflozin, as we've seen, that it was mostly patients who did not have an event before. But despite this, there was a 27% reduction of heart failure hospitalization. I think Dr. Ali showed a slide like this, so I'm not going to go through it. Now we will, after this cardiovascular outcome trial, then people looked at it and thought, okay, well, these patients, these agents, it seems like they can do magic to heart failure hospitalization. And so they started to look at the effect of the heart failure by these medications. So then they went and recruited patients with or without diabetes. And that is a very bold move to use an anti-diabetic medications for patients who did not have diabetes. And consequently, this DAPA heart failure study was designed. Basically about 4,744 patients. Either they have diabetes or no diabetes. They have heart failure, history of heart failure with low ejection fraction, and to be class 2 to 4, and they should have an elevated pro-BNP. They used patients with impaired renal function. They went up to EGFR of 30 ml per minute or more. And they put or recruited equivalent placebo group. We will not go through the details of the exclusion and inclusion criteria. We just mentioned it: people with diabetes, with heart failure, with ejection fraction 40% or less, having confirmed elevated pro-BNP and so on. Diabetes type 1 is not included. If a patient had a recent event like revascularization, they were not included because they may have an event, they may enter in hospital again, or they may die because of the revascularization. So they are not stable, so they will not be included in the trial. And this is basically the look at the placebo and the treatment group. And they are matching groups, as you can see. And the majority, they had ischemic etiology. They are well-treated patients on diuretics, ACE inhibitor or ARB, and so on. And the result, the primary endpoint, which is cardiovascular death or heart failure hospitalization or any urgent visit with heart failure. If, for example, a patient comes to the emergency department because they have acute heart failure, they did not need admission, but they had an IV in the emergency department or in the heart failure clinic, so that will be counted as an event. And there was a 26% relative risk reduction of events. And if you look at let me just use the pointer. If you see here from the beginning, the graph started to separate. Within the very first few weeks, the graph started to separate. So there was a relative risk reduction of 30%. And look at this. This is only for about 2 years. So these are patients high risk. If they receive this agent and they take it for 2 years as per this trial, their chance of having cardiovascular death or to need to come in hospital is reduced by 30%. That is as good or is better than our current medications for heart failure. And the components of the primary endpoints, the cardiovascular death was also significantly reduced by 18% within 2 years. The death in the placebo group was more by 18%. That is very significant. They looked at different primary endpoints by pre-specified subgroups, whether they have diabetes or no diabetes, whether their eGFR was above 60 or below 60, and their class of heart failure. So everything, it seems like the treatment group fared better than, there is no group at all fared better with the placebo group. Whether the patient has diabetes or no diabetes, there was no difference when they classify them separately. They all benefited by having the dapagliflozin. All-cause death was also a secondary endpoint, was reduced by 17% relative risk reduction. Now, I'm sure all of you, they thought to look for hypoglycemia. And there was, because we have patients who are not diabetic, so there was no more hypoglycemia in the patients who were receiving the dapagliflozin and they were not diabetic. In fact, the hypoglycemia was low in the diabetic and non-diabetic, but it was like about 2% in the diabetic, of course, because they take other anti-diabetic. So basically, this agent, you can give it to patients who is not diabetic to treat heart failure without worry of hypoglycemia. And these are they looked at adverse events because of the excretion of the glucose through the urine. They thought maybe have a volume depletion, and there was no volume depletion. So to summarize the DAPA-HF, that it is a fairest heart failure outcome trial with an SGLT2 inhibitor investigating the treatment of heart failure in adults with heart failure with the reduced ejection fraction on top of the standard therapy, which includes the guideline recommended for patients who are diabetic or not diabetic. and dapagliflozin provided a statistically significant and clinically meaningful reduction in the risk of worsening heart failure events and cardiovascular deaths when compared to the placebo as well, by improving the heart failure symptoms and when it is added to standard therapy. And when it comes to safety, there was no safety issue. As a result of this, in the beginning of May of last year, the FDA, the American FDA, approved dapagliflozin for a new indication to treat heart failure with or without diabetes to lower the risk for cardiovascular death on hospitalization for heart failure. And only last month, the Saudi FDA also approved dapagliflozin for an indication to treat adults with symptomatic heart failure in patients with heart failure with reduced ejection fraction, whether diabetic or not diabetic. They looked at what does this dapagliflozin do to patients who were not diabetic. So these are the baseline, the euglycemic or the diabetic status of patients. There is a large number who were pre-diabetic, and some of them, of course, diabetic, and some of them they were normal. And they saw that patients who received dapagliflozin who were not diabetic at the end of the trial after 2 years, there was a 32% reduction of the incidence of diabetes in the treatment group. So these patients who received dapagliflozin for the heart failure, they develop less diabetes by a significant 32% than those who received the placebo. And we are talking here about only 2 years. That is very significant. This is very quickly, for the sake of time, is just also to look, this is a secondary analysis to the trial to see if the patients will develop or actually they thought maybe it will help the hyperkalemia that is sometimes developed. And they looked at the patients that received dapagliflozin. And the conclusion is that heart failure with reduced ejection fraction, taking the MRA, the aldactone, which tends to have hyperglycemia, who were randomized to DAPA, they had half the incidence of moderate or severe hyperkalemia compared to placebo. There was no difference in the risk of mild hyperkalemia. So these data suggest that the DAPA attenuates the risk of moderate to severe risk of hyperkalemia in MRA-treated patients with heart failure with reduced ejection fraction, and may facilitate the use of MRA in patients with heart failure with reduced ejection fraction. The last part of my talk is only another 5 minutes, and hopefully we'll finish that, the SGLT2 landscape in heart failure management. So dapagliflozin is the first, but not the only SGLT2 inhibitor to test the effect of this group on patients with history of heart failure with reduced ejection fraction, with or without diabetes. The Emperor Reduce is a trial that is tested the effect of the empagliflozin on patients with heart failure with reduced ejection fraction in a mixed population with and without diabetes type 2. And this is just to show you the comparison between the population of the DAPA-HF patients on the left and the Emperor on the right. I will just draw your attention to that. They went to the EGFR they recruited patients with EGFR of 20 or more. If you remember, the DAPA recruited patients with significant renal impairment, but they went up to 30 or more. And after it was a shorter trial, and after 16 months of follow-up, there was also a relative risk reduction of the cardiovascular death or hospitalization for heart failure. And if we are to go into, we know it's 2 different trials, but this is basically to exclude or rather to extract the main results. So when it comes to the worsening heart failure, the primary outcome, the combination of cardiovascular death or heart failure needing admission or hospital visit by 25% in the Emperor and relative risk reduction by 26% in the DAPA-HF. The heart failure hospitalization was more or less reduced by the same number of about 30 or to 31%. Cardiovascular death was significant in the heart, the DAPA-HF. It wasn't significant in the Emperor. The all-cause death consequently also was reduced there. And also the quality of life questionnaire was significant in the DAPA-HF. So this is a meta-analysis published in the Lancet recently, and it shows that when it comes to the primary endpoints, it's very clear. Both they did their job, and this is the last one here is the total, the combination, the analysis of the combination together. The advantage of the SGLT2 inhibitors in the treatment of heart failure compared to the other agents used to treat heart failure, that they have no hemodynamic effect, so no precautions needed on initiating them, and no need for dose titration, usually given a single dose. As you know, we've seen that in the beta blocker, the ACE inhibitor, you have to start a smaller dose and you build it up. Here, you just hit and go. Unlike other heart failure medications, they do not have electrolyte or renal harmful effect. To the contrary, they help to significantly reduce the deterioration of the renal function for those who has renal dysfunction. And of course, their cost is not as high as the ARNI. Seems like this would be the foundation therapy, maybe better. This one, the cornerstone for heart failure therapy would be beta blocker ARNI, because ARNI is shown to be superior to the ACE inhibitor or the ARB, the MRA, and the SGLT2 inhibitor. So patients with heart failure and reduced ejection fraction, we should use all these four parameters. So to conclude, that is patients with heart failure and reduced ejection fraction are at increasing risk of repeated hospitalization and death despite being on multiple evidence-based medicines. The SGLT2 inhibitors are now added to the algorithm of treatment for patients with heart failure with reduced ejection fraction. SGLT2 inhibitors have favorable properties of lack of hemodynamic effects, and they have proven renal protection and possibly protection against hyperkalemia. So to summarize the two trials, the benefit of SGLT2 inhibitors in patients with heart failure with reduced ejection fraction, they showed efficacy demonstrated in a broad range of patients with heart failure with reduced ejection fraction, significantly reduction in heart failure related endpoints, significantly cardioprotective effects, and significant renoprotective effect. The SGLT2 inhibitors are safe and effective in patients with heart failure with reduced ejection fraction, in patients with diabetes and without diabetes, regardless of the baseline heart failure with reduced ejection fraction treatment, and regardless of baseline renal function, of course, up to the limit that is 30 mils used in DAPA and 20 in EMPA. And thank you very much.
Thank you, Dr. Osama. That was really comprehensive and great review about HFrEF management and how you focused also on the SGLT2 inhibitor, which we call the new kids in the block. So thank you so much. So we have a few minutes left, so I'm just going to take a few questions and direct it to one of our speakers. So maybe I'll start with you, Dr. Ali, with the question is, so this question we get it all the time is like, when you see a patient with acute heart failure, what do you usually prefer? Like, should you put them on Lasix infusion or should you put them on boluses? Does it really matter? Like you talked about the dose trial, but does it really matter at the end of the day, which agent or which strategy do you use?
I think this is a very important question. And as I have mentioned in my slides, diuretics use, it's always dilemma what to use and how. For me, I think the question of comparing the boluses to infusions probably been answered by this trial, and probably there is no evidence-based like answer to tell this one is superior to other. However, I think it depends on the patient. For me, patients with advanced heart failure that I know and they require high doses of and more frequent doses, and I need like more aggressive diuresis and less electrolyte disturbance because of high dose of diuretics, I prefer continuous infusion. So what I see from personal experience, continuous infusion, you can easily up titrate to achieve your target with regard to fluid loss with less electrolyte disturbances. If the patient is less sick and 2 or 3 doses a day, that will help him to bring him to stable condition. For sure, there is no need for infusion because continuous infusion will limit his mobility, and it's less convenient to them. So this is my brief answer to this question. Yeah.
Okay, thank you so much, Dr. Ali. Dr. Osama, I have a question about the hyperkalemia in patients with heart failure. As you know, one of the audience is asking, like, a lot of the medication that we use to treat to treat heart failure with reduced ejection fraction can cause hyperkalemia, especially the MRAs and the ARNI and such medications. So other than like reducing the medications or is there any other intervention or strategies that you can do so that you can allow the patients to stay on these medications that have been proven to improve their mortality?
Yeah. Well, I think the most important thing is to anticipate what kind of patients may develop the hyperkalemia. So, of course, patients with renal impairment, even if it's a mild renal impairment, and these are patients you will not just give them the medication and send them away and see them after whatever, a month or 2 months in government hospital, as you know. At least we are in the private, we can see the patient after a week or even next day. So you have to see what kind of patients who is high risk, in order to give them a close follow-up. Then you start based again on their background and their renal function. You may need to start slowly. Say, for example, if you're giving them aldactone, you give them 12.5 milligram rather than 25 or 50. And then you build it up gradually by seeing them. It's important. I mean, as you know, in the West, whatever patients will go to the dietitian to give them advice about low potassium food. That is very important. I think we should also strive to use the service of the paramedical to help advising these patients. As you know, we in the clinic, we are very busy. You have a clinic with another 10 to 15 patients waiting outside, and you want it very quickly, you finish and see the next one. So then you give them the time in order to do this. And lately, we have some new agents that can be used for patients with severe hyperkalemia. Of course, we don't want the patient to reach this stage to be severe hyperkalemia, needing to come in hospital to need a specific, treatment for hyperkalemia. That's basically what it is: the anticipation and the close follow-up.
Okay. And as you said, there are some newer agents that are becoming available to treat hyperkalemia in this situation, but I think they haven't been adopted widely in most hospitals now. So it's something to watch out in the future.
Sure.
Dr. Ali, question is like for acute heart failure or like in general in heart failure, what tools do you usually use to assess your patient symptom improvement? Like some people use the Kansas City score to or questionnaire to assess. Is there, like, in your practice or in your when you see your heart failure patients, how do you usually assess their symptoms on all well-being? Is there like some sort of prognostic things you can do for them, some sort of test you can do to assess their response to therapy?
Okay. We have different tools to assess these patients. If you're talking about the level, I mean, if you are talking about assessment for possible discharge, I will go by simply clinical daily evaluation, like daily weight, GVP, the drop, the level of drop of pro-BNP. As you're aware that Canadian guidelines stated that you should probably discharge patients when they're at least drop their pro-BNP by more than 50%. If you're talking about the like patients are not deteriorating out and you want to calculate their prognosis and their the short-term mortality and to consider assist devices and probably transplant, I agree with you. Probably we should use some more advanced and sophisticated tools to assess their risk and mortality. If their risk of mortality is high in 6 months to 1 year, based on like different models that we're using, like Kansas City or Seattle Heart, and other tools that like Intermax and other tools, then probably you should use these to decide when to refer them for assist devices and more advanced therapy. Because as has been mentioned as a statement, being 5 months earlier in referring this patient better than being 5 hours or 5 days late. Because if you miss the boat for advanced therapies other than pharmacological therapy, probably you're not going to do much for this patient.
Dr. Osama, another question we have is a lot of people, they like, even this is my observation is like, when you prescribe SGLT2 inhibitor for patients, especially non-diabetics, a lot of people are getting worried. Like, let's say you describe dapagliflozin or empagliflozin to somebody, and let's say DABA 10, and then they're non-diabetic. So a lot of people worry that they're gonna go hypoglycemic. They're gonna develop their sugars are gonna drop. So what do you tell people who have this extreme, like they are extremely worried about
Sure.
this scenario?
Sure. Of course, their worries is justifiable if they know that this was originally an antidiabetic medications, but we have the evidence from the trial that there was the incidence of hypoglycemia was not there, was just equivalent to the placebo. And in fact, the patients who were diabetic, they developed more hypoglycemia. I mean, it was still small, but it was more than, so it is not a worry. You know, I will tell the patient that this is a story. Sometimes maybe you have to make it funny, like you mentioned the Viagra was not made for what is now used for, but then they discovered that it does what it does. So these are medications which originally made as anti-diabetic, but they found that they do marvelous job for heart failure, and they tested them for patients who are not diabetic like yourself, the patient in front of me, I'll tell him, and they found that there is no question of hypoglycemia in this. So they will help you, but they will not harm you.
Okay, great. Dr. Ali, a question is, do we have local guidelines for heart failure management in Saudi Arabia? Like, do they exist, or for people if they want to look at them, or what do you recommend? Like, which guidelines do you usually recommend for people to look through?
In fact, I was part of the Saudi heart failure group that was published, the first Saudi heart failure guideline that was there out like 2019 and published in Saudi Heart Journal. This guide, I mean, this is the only local guideline that we have for heart failure. I think it's a reasonable, good start to have local guidelines. We need to work more. Definitely, it needs to be updated. I recommend those who are interested to review these guidelines. I think lots of information in there, plus what we have available from European Society of Cardiology and American Heart Association guidelines.
Okay. Finally, we're running out of time, but the final question to Dr. Osama. So you talked about a lot of, you talked a lot about SGLT2 inhibitors for HFrEF, but can you tell us just briefly if there's anything about SGLT2 inhibitors in HFpEF for those with preserved EF? or is anything coming on down the pipeline?
Yeah, sure. Well, I mean, as part of the portfolio for studies, all these agents, the DAPA and the EMPA, they have studies which are currently running to look into patients. They are already in the middle of the trial, and I'm not quite sure about the time. At least by next year or maybe the year after, we will have the result of these trials. And of course, we are all excited to see if this a nut that has been very difficult to crack, all these agents before they failed to crack it. I hope the SGLT2 inhibitor will crack this nut, and then they will give us benefit. But we have to wait and see.
Okay. Okay. I would like to thank Dr. Ali Masoud and Dr. Osama Al-Bashir for their amazing talks and their open just to take our questions. I would like also to thank the audience for attending on a Friday night. That hopefully that was very helpful in understanding how to deal with acute heart failure and how to try and optimize medication for HFrEF patients, because as both doctors explained, those patients are sick, and as like Dr. Ali said, heart failure is like cancer. So it's exciting now we have some newer agents such as ARNI and SGL2 inhibitors to use. So hopefully this will reflect on everybody's practice. Finally, I would like to also thank the Saudi Heart Association for their supporting and organizing this event, and also for AstraZeneca for supporting and organizing this event. And I hope we'll see you everybody in the near future for another talk and another presentation. Thank you so much.
Dr. Musaad, before we go, just remind you, there is this survey that is, there are 3 questions. So they are waiting for us. If you just go ahead and mention it, so then we can mention it to the audiences.
Yes, so sorry, we have a 3 question survey that if everybody will be kind enough to answer, and then we'll conclude.
So question number 1, it's I believe that heart failure patients in Saudi Arabia are having high ongoing risk of mortality, and current standards of care have several limitations to control the mortality and more of these patients' symptoms. So the answer is yes or no, and the same thing for the second and the third, yes or no. And hopefully our chairman will tell us further the result of the survey.
Okay. Sorry, so I'm just getting it in front of me. So if you don't mind, the audience, if you don't mind just answering the poll. Just 3 questions. Okay. So first question, I believe the heart failure patients in Saudi Arabia are having a high ongoing risk of mortality and has severe limitation to coronary motivation. So 84% of the patients said yes. I'm aware about DAPA-HF trial that for CJA have evidence and effective in treatment of heart failure with reduced ejection fraction in patients with diabetes or without. 77% said yes, and 23% said no. And I'm willing to use dapagliflozin or Forxiga on the top of standard care for heart failure patients with reduced ejection fraction. So good. So a lot of people are hopefully going to adopt the cornerstones of heart failure therapy, which are the 4 medications: SGLT2 inhibitor, ARNI, MRAs, and beta blockers. So hopefully we'll have very well treated patients in the future. Again, thank you for the audience. Thank you for the speakers, and thank you for Saudi Heart Association and AstraZeneca for supporting this event. And I'll see you guys in the near future, inshallah. Ma as-salama.